I'm going to carry, can you guys hear me? It's working? So what I'll do is I'll hold the microphone. I think what I'll do is I'll put down my coffee, and I'll hold the microphone, and I'm going to go around if people have questions, comments, whatever, and have you also speak into the microphone, because I think they're recording or broadcasting or both this session. So my name's Andy Mammen. I am part of the Johns Hopkins Myositis Center. I was one of the co-founders of that center back in 2007, and in 2014 I moved my lab to the NIH, where we continue to work on myositis, including a lot on necrotizing myositis. That's one of our main areas of interest, and I continue to see patients at Johns Hopkins as well. So I may just start by giving a little brief introduction to kind of what I think about necrotizing myopathies and how that fits into the world of myositis. So back in about 1976, there were a couple of physicians named Bohan and Peter, and they went and they looked at all the different myositis patients that they had, and they basically broke them down into two groups. And they said you've got patients with dermatomyositis and you've got patients with polymyositis. And the only really difference between the two that they recognized was that the dermatomyositis patients had rashes and the polymyositis patients did not have rashes. And a bunch of time went by, and during that time it became recognized that some patients who everybody was calling polymyositis actually have now what we think of as inclusion body myositis. So patients who had progressive weakness that didn't respond very well to immunosuppressive therapy, and it's really kind of a different disease category than dermato or polymyositis. And then during that same time period, people started looking at the muscle biopsies of patients really carefully. And what they realized is that most patients, and it was previously out that all patients really had a lot of inflammation in their muscle biopsies. And there were lots of inflammatories and cells in there that seemed to be doing the damage, both in dermatomyositis and polymyositis. But there was a smaller group of patients that didn't have any inflammation in their muscle biopsies. All they had was dying muscle fibers and also regenerating muscle fibers. And another word for cell death is necrosis. So these were called patients who had a necrotizing myopathy, and they're thought to be almost all those patients, not all, but almost all those patients who have a necrotizing myopathy don't have the classic dermatomyositis rash. So it's thought that that the necrotizing myopathy, and some people think of it as a subset of polymyositis, like one kind of polymyositis. I tend to think of it as just a separate disease category altogether, and that we ought to think about that separately. Now, while people were looking at the muscle biopsies and trying to figure out how to divide patients by muscle biopsies, there were other groups of people looking at autoantibodies. And I think most of us, when we think of antibodies, if we know anything about them, we think those are proteins that are circulating in our blood that recognize foreign things like bacteria, viruses, things like that. And the antibodies are there to help get rid of all these foreign things. But some people with myositis make autoantibodies, meaning that antibodies aren't directed against viruses or bacteria, they're directed against you, against some part of your muscle, probably. And over the past number of years, we've realized that there are two autoantibodies that are very tightly associated with necrotizing myopathy. And one of them is anti-SRP, or anti-signal recognition particle. That was one of the first autoantibodies that was ever discovered. It was discovered in 1980, I believe, and it's been around for a while, but now we know it's really associated with necrotizing myopathy. The other one, our group discovered, and it's against something called HMG-CoA reductase, which physicians knew what that protein was because it is the pharmacologic target of statin medications. And so it turns out that at least in our group of patients, about 2/3 of those who have antibodies against HMG-CoA reductase had previously taken a statin. And we're pretty sure that that serves as a trigger for developing the autoimmune muscle disease. There are other patients who have necrotizing myopathies who don't have either one of those two autoantibodies, And then that's a whole different situation, and it can be one of a number of different things. And this is where it gets, that so far it's pretty, is everybody following me so far? Okay, here's where it gets a little bit more complicated. If you don't have SRP or HMGCR, and you still have a necrotizing muscle biopsy, then there's lots of things you could potentially have, and they're each different. So some patients with lupus have a necrotizing muscle biopsy. That's probably the most common thing we see in patients with lupus. Doesn't mean you have lupus if you've got no antibody. Some patients with scleroderma have a necrotizing muscle biopsy, but not anti-SRP or HMGCR. Some patients with cancer will have a necrotizing muscle biopsy. And then, just to make life really difficult for us, some patients with dermatomyositis have predominantly necrosis on their muscle biopsy with not a lot of inflammatory cells or the other typical DM features. So that's about 15% of dermatomyositis patients have what looks like a necrotizing muscle biopsy. Most of them have rashes, so they're not actually usually mistaken for having what we think of as like the SRP or the HMGCR type. And then there's a few patients, again, about 15% of patients who have what's called the anti-synthetase syndrome. I don't know if you guys have heard of that, but that's associated with the Jo-1 autoantibody. Those patients typically have myositis, lung disease, arthritis, special kind of rash called mechanic's hands. And just to make life complicated for us, about 15% of those patients have necrotizing muscle biopsies. So actually, I don't really think of necrotizing myopathy as a single disease. And I think of people who can have a muscle biopsy that looks like a necrotizing and have multiple different diseases. What really tells me what disease people have is what autoantibody they have. So if you tell me I have anti-SRP autoantibodies, I can tell you all kinds of things about that disease. It doesn't really matter what your muscle biopsy looks like. In fact, about 20% of anti-SRP patients have inflammation on their muscle biopsy. You might call them polymyositis, but they're otherwise the same as everybody else with anti-SRP. Same with anti-HMGCR. We call those patients all probably have the same disease, but only about 70 or 80% of them have necrotizing muscle biopsies. The other 20 or 30% have inflammatory muscle biopsies. So I tend to think of it as by autoantibody. So if you're sitting here and you tell me what autoantibody you have, I can tell you things like what I think your prognosis is going to be, what kind of treatments we think work best, and that kind of thing. If I don't know your autoantibody, then it's not so simple in terms of what I can tell you about your disease. Because again, these antibodies really are what seem to divide patients up into really meaningful different groups of patients. So just to get a show of hands, do people know what autoantibody they or their loved one or whoever has? Yeah, so most people, yeah, almost do. That can be helpful too. Knowing what you don't have can be helpful. Yeah. NT5C1A, yeah. Yeah. So sometimes those antibodies are very helpful in telling us what type of disease people have, regardless of what the muscle biopsy looks like. So that's sort of that'd be my kind of overview of how I see the different autoimmune diseases, how we kind of define them. We got about 12, 20 people up here. Some of those people would give you different answers as to how they think myositis ought to be divided up. But of course, I'm right. No. But that's how I think of it. I think it's a useful way of thinking it. We may revise it as we learn more about these diseases. We're not stuck on that. But I think that's the most up-to-date way of thinking about it. I'm going to give you the microphone so people can hear.
How easy is it to diagnose the necrotizing myopathy from the biopsy? Is it pretty clear cut or not?
Great question. So really the question is like, how easy is it to tell from the muscle biopsy somebody has a necrotizing muscle biopsy? It's in the eye of the beholder. Reading muscle biopsies is not like getting like your CK back. It's 542 and everybody can all agree that the CK level is 542. If you give muscle biopsies to each of us up here on this panel, we will give you different answers about what we think that muscle biopsy shows. It's a huge problem. So I recently ran into this working with somebody on a paper, and I gave them a picture of something from a patient saying, this is necrotizing, here's a great picture to put in our paper of necrotizing myopathy. And they were like, well, we don't think this is a very good example of necrotizing myopathy. And they're like, experts also in this area. But I sent it around to 3 or 4 like world expert people, and they all agreed that what's the argument? This is necrotizing myopathy. But my point is that people who don't read a lot of muscle biopsies are probably more likely to be off on whether that's what it is. And then even among people who supposedly know, there can be disagreement about, well, how many myofibers have to be dying before you call it necrosis? Is one abnormal? Or do you have to have 2, or what's the number? So there aren't defined criteria for this. We're actually meeting in Amsterdam in a couple weeks with a bunch of international experts to try to come up with very specific guidelines about how it should be defined based on the muscle biopsy. But again, what I would highlight is that the antibody would trump the biopsy. If you have inflammation on your muscle biopsy and you're anti-SRP or whatever, you've got anti-SRP. And I think of you just like all my other anti-SRP patients, whether they have necrosis or inflammation on their muscle biopsy.
So basically,
I'm giving this to you so other, yeah.
So basically, the diagnosis was given, and then over the period of say 6 months, your rheumatologist and some of the other doctors are questioning the diagnosis, I guess, based on just the clinical side of things. Is that normal for that to happen? And what clinically can you see that would sort of put that into question?
So what I would say is this. If you have a necrotizing muscle biopsy and you don't have if you don't have SRP and you don't have HMGCR and you don't have another defined rheumatologic illness like lupus or scleroderma, and if all you have is skeletal muscle involvement, meaning your lungs aren't involved, your skin's not involved, your joints aren't involved, but no antibody, I don't really care what the muscle biopsy shows. I'm not sure what you have. I may not be sure, because there are people with genetic muscle diseases who can look like that. So I will look for genetic muscle diseases in patients where I don't think I have a solid diagnosis of a kind of autoimmune muscle disease. I may treat them like they have an autoimmune muscle disease anyway, because it may take me a long time to figure out if they have a genetic muscle disease. And they may have a genetic muscle disease I can't figure out. So I will often still treat them very aggressively with immunosuppressive medication on the assumption, even without knowing for 100% for sure, that it is autoimmune.
I want to ask about repeat testing. I've been on IVIG for 17 years, and I'm wondering, would it do me any benefit if my disease is in a state of homeostasis? Would I have a positive antibody test?
So I think that the question is like, yeah. Yeah. So if you have one autoantibody, if you know you have one autoantibody, it's very unlikely, very, very, very unlikely you would have another one. And if you had it once, you've got that, and it was, a definitive yes, you have the autoantibody, it is pretty, with some, it depends exactly when the testing was done. So, this is like a whole bag of worms. If the diagnosis doesn't make sense, sometimes I would repeat the antibody testing. For example, there was one company that did autoantibody testing for a while, and they were having a bunch of false positive anti-PL7 and PL12 antibody testing. That's a kind of anti-synthetase autoantibody. And I would look at the patients and be like, you don't look like you have the anti-synthetase syndrome. So we'd retest it, and it would be negative. I think that problem has been solved. Another big problem for us for a while was that some of the SRP has 6 different proteins on it. and the testing that they would use only tested for one of those. Now, most people who have anti-SRP do have that one, but there's probably 20% who don't have it. So we early on made the mistake of calling things like, you look like you've got anti-SRP myositis, but your anti-SRP autoantibodies are negative. So we would retest them ourselves or send them to labs that do more comprehensive screening, and then I'd find out that they're actually positive. I actually treated one patient for years not knowing exactly what she had. She was originally given a diagnosis of dermatomyositis, but never really had a typical rash, and she was doing really poorly. I re-biopsied her. It was necrotizing, and I sent her, she had already been tested twice for anti-SRP, but I sent it to a more reliable, sophisticated lab, and it was positive. And it made sense with her clinical picture, and it changed what we were going to do in terms of medication treatment. So that's like a long-winded answer to your question. I can't answer it. When to retest antibodies, when to reassess the diagnosis is something that's very, very individualized. Yeah, I can't really generalize too much about it.
Hi. Have you ever seen extremely large calcification in someone with that word? Yeah.
Yeah. So calcification, I don't know if you guys are familiar with this, but some patients with dermatomyositis in particular, but also scleroderma and some other diseases get deposits of calcium underneath their skin. They can actually erode through the skin. It can be a major problem. We rarely see that in SRP. I've never seen an anti-SRP patient who has that. I've never seen an anti-HMGCR positive patient that has that. But it's possible someone could have, like I was alluding to, dermatomyositis, a necrotizing muscle biopsy, and they could have calcinosis. But really, we think of those as being predominantly dermatomyositis patients.
Okay, so I have two questions. I was positive for the anti-HMGCR. I've never been on a statin. You were saying that you have a specific protocol or a specific treatment that you like to do with patients like that. And then two, it came back positive the first time we tested. Then they tested again, and that one came back, it didn't come back positive. Is that because maybe I'm on IVIG now, or do you think the first test could have been, so we're retesting now again to see?
For anti-HMGCR testing, as you pointed out, you don't have to have taken a statin to have that. The testing that they do commercially has a 1% false positive rate. I mean, if you took, or 0.7%, if you took 1,000 people who are healthy, 7 of them would have a positive test. So it is possible to have a false negative anti-HMGCR test. We have never seen anyone with and we do that, the type of screening they do commercially, then we do an additional test on top of that is more labor intensive to verify that people are truly HMGCR positive, so that we really know for sure. And we have not seen patients go from having an antibody to not having the autoantibody. So if I were to see that, it doesn't mean it's impossible. Just because we haven't seen it doesn't mean it's impossible, because other people have reported that they see it. But that does make me wonder whether the first one was true or not. It would kind of depend about other things about you, like does it all fit together? Is everything like anti-SRP should be? And then in terms of the treatment for, anti-HMGCR, the treatment for anti-HMGCR in people who are over the age of 50, people do really well, usually with IVIG, and sometimes we just use IVIG alone as like single therapy. It kind of seems to be the magic bullet for some people. In patients who are younger than that, and the non-statin exposed patients tend to be the younger ones, we sometimes have much more difficulty treating those patients. We have to use multiple treatments. It can just be a very aggressive disease. Like anti-SRP myositis can be in younger people as well. So So younger people tend to be much more difficult to treat. We tend to be really aggressive, and we don't know for sure what the best treatment is for younger people. We think for older anti-SRP patients, we think for older HMG-CR patients, IVIG, again, the younger ones, we try a variety of things to try and come up with what works. I was going to get you.
I was diagnosed in 2010, and my CPK was off the chain. And I got 1,000 milligram of prednisone, and I'm tapered down to 10 now. I have never given any of the tests that I hear you're talking about, the Joe and all these tests. So I'm wondering, methotrexate and prednisone works for me. And I'm wondering if I should just let it be or ask my doctor to go and take all these tests, since I'm not in any trouble.
So in a way, there's two parts to that question. One is, should you change, if you are tolerating a treatment well and it's working well, I kind of tend not to mess with that. It might still be interesting to know what autoantibody that you have in case that treatment stopped working, because then I might have some idea about what the next thing ought to be. And you can get that done at commercial laboratories. Yeah. If you have a necrotizing muscle biopsy, do you have a necrotizing muscle biopsy?
No, I've never had any of those. It's the muscle biopsy.
Right. And what did the muscle biopsy show?
That I have a
Right. So it would depend. So you can send off your blood work to one place and they'll test for a bunch of different antibodies, except for HMG-CoA reductase, has to be ordered as a separate test. So you might do the one first that has all the bunch of different antibodies, and if everything's negative on there, you could do the anti-HMG-CR test separately, or the NT5C1A. You can stay where you are.
Thank you. I have necrotizing myopathy, and I'm anti-SRP. And when I thought all I had was polymyositis, I was on kind of the normal prednisone, methotrexate, Imuran, IVIG. We've now got me down to just IVIG and prednisone, and I have a doctor locally who really is cautious about not wanting to take me off of prednisone. So what I'm thinking is, if I hear you saying that with necrotizing and anti-SRP, I don't really have inflammation, I have necrotizing cells, is prednisone doing any good for that?
I don't think we know for sure whether prednisone is doing. That's a trial and error thing. Some patients appear not to respond to prednisone. For other patients, prednisone actually does work pretty well. I don't know why different people are different. If I'm trying to understand whether prednisone's doing anything for somebody who's already on it, my thought would be I slowly, ever so slowly taper it, provided you're not on a super high dose, in which case I would go faster. Yeah, if you're on 10, I don't know. The only way to find out whether that 10's helping you is to slowly decrease it. And you can decrease it by like 1 milligram a month. And with a necrotizing, you're in one of the sort of good things about necrotizing myopathy, which is different from dermatomyositis or other types of myositis, is that the CK level is actually a pretty good indicator of what's going on with the disease activity. So if you start to taper, the steroids and your CK starts to go up even though you're feeling pretty good, that has me worried that we ought to go back up on the prednisone, that it was actually doing something. So following the CK can be really helpful in people with necrotizing myopathies. Yeah, so you're anti-SRP, is that what you said? So, and the other silver lining for you is that people with gray hair do the best with anti-SRP. Yeah. Hopefully people with no hair do well too, but we haven't looked into that.
Yes, some of the other presentations here, they've mentioned the antibodies with the anti-SRP. They usually talk about being severe, rapid onset. I have the SRP antibody, but it was very gradual. Well, I wasn't diagnosed. When they first found it, I was probably 40, I guess. Okay, but mine was real gradual, wasn't rapid onset. That's some of these presentations, you know, they've said it's real rapid, severe, and that's.
Yeah, so we often we speak about how things are as if that's the way it affects everybody. Those are kind of generalizations. On average, it's more rapid onset than some of the other forms of myositis, but everybody's different. HMGCR patients, I would say, some of them that we see have high CKs for a long time, and it takes a long time for them to get weak at all. You know, we've seen that. We've seen that before with HMGCR. That's actually pretty typical in the older patients. Younger patients, we've seen people just crash, you know, and go from being fine to being in a wheelchair in months. So part of it's an age thing, part of it's which antibody it is, part of it's just luck of the draw. Yeah.
This is a quick one. How long would a lab or hospital hold on to a biopsy? How many years?
So it depends where you had it done. At Hopkins, we have the muscle biopsies going back to the 1960s, and we even have the frozen muscle biopsy specimens going back decades at least. So we can go back, if there's new stains or something available, we can recut the tissue. Sometimes it's not in great shape, it doesn't work, but often we can go back and look. The slides are usually held on to even for, you know, longer than that. That's what they actually look at under the microscope. So in general, those things should be kept. They might be in deep storage somewhere. Yeah. Yeah. They wouldn't have thought it. They wouldn't have necessarily thought about it, that classification. But I don't know. I mean, I don't know your whole story, but it would be unusual for that to change what the thought process is about what's going on now, to look at the biopsy. It'd probably be easier to just look at the antibodies. Yeah.
Kind of follow up from that previous question. So if they do have it and the lab has it, say they keep it for 2 years, is there a way for you to get it transferred somewhere else so it can be kept longer?
Yes.
Okay. You just have to find out where that place is? Or how's that work?
I mean, so you have to find somebody who's interested in holding on to it. So like Hopkins, we have muscle biopsies sent to us from other institutions all the time. I personally don't trust other people's reading of the muscle biopsy. You know, I've literally had muscle biopsy reports from patients that said, no inflammation, no rimmed vacuoles, which to a lot of people means like this is not inclusion body myositis, no rim vacuoles. And I get the biopsy and I look at it, and it's like, we could put this in a textbook. There's so many rim vacuoles in here. So it does make sense to have muscle biopsies read at places that are good at doing it. Usually when we get those, we're very careful about sending them back to where we got them, because usually the other institution wants to keep them. But I imagine if you made a special request, it's like, hey, these are my muscle biopsy slides. I want them to be here or there. I think that they would potentially go along with that.
Dr. Marmon, I've been on a good regimen of just 50 milligrams of Imuron. I have polymyositis, anti-SRP, and the biopsy did show some necrotizing myopathy. But my question to you, and I appreciate what you just said, that if you see the CK levels and you're still feeling fine, can you repeat what you were saying? I'm sorry.
So it's about CK levels in necrotizing muscle biopsies. Or in anti-SRP and anti-HMGCR, I would put it that way. The CK is a good indicator of disease activity, meaning if the CK level is high, there's some muscle damage going on. Okay? And if the CK is normal, there's probably no muscle damage going on. That means that you can use the CK to tell whether people's disease is becoming more active even before you notice a change in their weakness. So unlike other forms of myositis where I kind of treat the weakness, I will sometimes treat the CK in people because I know if they're going even if they're feeling strong, if they're going from 2,000 one month to 3,000 to 4,000, I know that they are going to be weak and that I'm going to intervene because that CK number is going up. Does that make sense? But there's one other thing about the CK, and that is that in people with anti-HMGCR and anti-SRP, sometimes, and a lot of times, even when people get to normal strength and feel really pretty good, their CK level may still be elevated, sometimes markedly elevated. I have a couple of patients who walk around, they feel like they have no disease, they are not limited, they're traveling to Africa and doing all kinds of stuff, but their CK is 2,000. You know, and I have other patients, if their CK goes up to 600, they're going to be weak. So we will sometimes tolerate a high CK level in patients with anti-SRP or anti-HMGCR as long as they're strong. There probably is some disease activity going on, but I don't know that it's worth the risk of additional side effects to try and push the disease activity down if they don't have any limitations. Does that make sense? Yeah. Yeah.
So on the converse, my CK levels have been normal for 2 years. Yay. And he thinks I'm in remission. But I feel, even from last year's conference, that I've had some more increased weakness. Would it benefit me? Because I feel prednisone did not help me. Yes, 50 milligrams, so I'm finding that's a lower dose. And I think he tried to wean me to 25, and then I felt something from that switch. So he said, stay at 50, but since then I haven't felt as strong as I did. What would my next logical thing?
So the question in your case is whether you have active disease that you ought to be treating, and the CK isn't helping you. Now, usually the CK we think is a pretty good indicator, but if there's a question about it, the other thing we can do is a muscle MRI, okay? Because sometimes people have normal CK levels with these diseases, and they're still weak. And it's like, well, why is that? And the most common explanation is that permanent damage was done to their muscles. And we can't bring that muscle back, that there was some permanent damage to it. So by doing a muscle MRI, you can look, is there a significant amount of fatty replacement of the muscle? And if that's the case, and your CK is normal, I'm going to say, I'm really sorry, but I don't think like treating you more aggressively is going to bring that muscle back. It's kind of gone. But it also lets us look at the remaining muscle and see whether it looks normal or whether it looks inflamed. So I do have some like very severe anti-SRP patients where they've lost a bunch of muscle, and so much so that their CKs don't go up anymore, okay? So, sorry? Because there's not enough muscle. They have some muscle. It's not like they're paralyzed. They're usually significantly weak, but they no longer have enough muscle to mount a CK elevation. And in those patients, I will have to do MRIs to figure out whether, I will sometimes have to do MRIs to figure out whether the treatment is working or not, because what I look at is the edema, the inflammation in the muscle. So if there's still inflammation there, even if their CK is normal, I may get more aggressive about treating them. So that would be one thought, would be thigh MRI. Am I weak because I have fatty replacement, or am I weak because I have inflammation in my muscles, or is there some other reason that I'm feeling weak? Yeah. And then,
what kind of CK level are you looking at with your patients? Like, what would you consider high?
So that is very individualized. So I don't know what the highest CK is that you can tolerate. So it might be that it's 3,000. It might be with a CK of 3,000 you have no weakness. But for you, it might be you need a CK of 500 might be too high, and you still feel weak, and I have to get it lower. So I think it's an individualized thing. But I I've begun to worry about letting people CK ride really high. And I think I've seen some people where I haven't treated them because their CK has been high, but they've had normal strength, and then it starts to go up. And then they start to get weak. And then I have a really, really hard time treating it. It's like maybe I let the disease sort of get out of hand. So we don't know the answer to that. But there's some people who think we ought to be pushing the CK to normal in everybody. And it may be that that's the right answer, but we don't know for sure. So yeah, so I'll just repeat the question. So I think the question is, you're diagnosed relatively recently, you're getting better, but how do you know, how much better? How often should you be checking the CKs? What's the measure of improvement? I mean, ultimately, the most important measure of improvement is strength, and more so than what I say, whether you're stronger or not, whether you're able to do the things that you were able to do before. One of the things that happens is that people change their sense of what's normal. So like I'm constantly learning new things. A few years ago, I had a patient who had anti-HMGCR. She was maybe in her 40s. She'd never had a statin. I treated her, and she got a lot stronger. Her CK was then like 700, and I was following her. It's like CK 700 or 800, maybe it's been 1,000. But she was like totally strong. I'd ask her, are you feeling normal, or are you feeling like limited in any way? And she was like, I feel fine. I'm fine. I can do all the things I want to do. And her local rheumatologist wanted to add IVIG to her regimen. And I said, yeah, wouldn't really do that. I mean, IVIG is not without its risks. You're not having any problems. I'm not that worried that your CK's 800 or whatever it was. And she didn't listen to me, and she went and she took the IVIG. She's shaking her head, but actually, she came back like a few months later and said, I can now run. I used to be a runner, and now I'm out like running 5 miles again, and I couldn't do that before. So, so people will change what they think they should be able to do, or people think, well, I'm getting older, maybe it's just that. So in her case, I think she did it was not what I said she should do, but I think it was the right thing for her. She actually felt stronger, and it worked out well. It's changed my thinking about it. So I will now offer that to similar patients. I will say, I don't know what the right answer is, but hey, I've had another patient or two who felt like they were pretty good, but when we drove their CK down even farther, they felt better. And some people want to do that. Some people are like, I don't want to take the risk of other side effects. But strength is the main thing. It's whether you can do the things you could do before. And the CK is helpful, but I think of it as a secondary thing, not the primary thing. If I know what's going on, like I know what the autoantibody status is, and I'm treating somebody, and then I will check it once a month. And the other thing to know about CKs is that they can vary a lot from day to day. So I wouldn't get all worked up if your CK goes from 3,000 to 4,000, if it's that high, or 300 to 400, or those kinds of changes aren't that big of a deal. Trends are helpful, like which way is it going from month to month. Sometimes if I'm really concerned, I'll do it every 2 weeks. But as the months go by, I'm more likely to do it once a month. And then as people get under really good control, I might do it every other month. It's, it's person by person, situation by situation.
I'm not sure if this is the place to ask the question, but my wife has IBM, and she has pain in her legs. Is there any treatment for that at all?
Excellent question. We talked about this a little bit in the IBM session. There's many IBM patients and patients with necrotizing myopathy too can have muscle pain as a part of their disease. Some of my patients will, like the first thing that happens when their disease starts to flare is, I'm getting some pain in my thighs, and we'll check their CK and it'll be elevated. So some people have that. For people with necrotizing myopathies, usually the answer is treat the underlying disease, you know. But for IBM patients where we don't have good treatments for the underlying disease process, sometimes we have to use pain medication, and I'll send people to like pain management specialists. But there's nothing, it's trial and error, trying to figure out something or some combination of things that work for individual patients. The important thing is to find somebody who's committed to working hard at figuring out what that is with you. And that can be the big challenge. I was going to give it to, I'm terrible at figuring out who deserves the microphone next. Sorry about that.
It's okay. Hi. Yeah, I have sort of kind of like two questions. The first question is, like right after I got the muscle biopsy in my right quad, I started having like a hot and burning sensation and like pain, like on the right side of like the upper thigh, but by the knee. So they really tried to treat it with gabapentin, but gabapentin gave me tremors really, really bad. So I got off the gabapentin, and then like every now and then, like it'll get burning hot, and then I'll get like those sharp shooting nerve pains. So I'm trying to figure out like what is it, or the underlying treatment for it that I can do to kind of like sort of like treat that.
Yeah. So it's pretty rare to have the kind of pain you're describing after a muscle biopsy, or maybe people don't talk about it as much, but I'm not sure. But I think it's unusual. It's probably, I don't know for sure, but it could be because you could have had a nerve going through the skin and they actually, cut that nerve, and so now you have some neuropathic pain from that. When did you have the biopsy? So that's now a long time ago. So sometimes that kind of pain goes away. If it doesn't, then gabapentin would have been my first choice too for treating that. But there are other pain medications, and again, I don't know which one's going to work for you. You just have to do trial and error through different ones. But if it's a significant problem, it's probably worth trying different pain medications. Sometimes, again, working with a pain management specialist is the best way to go. Were you after this? No, you were after. Okay.
I just want to ask you, my CPK is 98 now from over 5,000.
Yeah.
And I'm looking at that as being good. But I still have the muscle weakness climbing stairs.
Yeah.
So any elevator or anything, I'll take it because it's hard to climb upstairs.
Right. I don't know for sure why that is, but one very likely explanation, if you had severe weakness, was your weakness pretty severe when your CK was 5,000? Yeah, so some people have permanent muscle damage and will continue to be weak even when their CKs are normal and they're really well treated. And you don't want to add more immunosuppressive medication on in that situation. So again, a muscle MRI can be helpful, like a thigh MRI, and you can see, is there a lot of fatty replacement there? If there is, that kind of answers your question. Yeah, and it's not, that is very common, to have some residual hip flexor weakness especially is the most common place where people have had really chronic muscle damage.
Earlier you were talking about CK levels being at second line regarding, I guess, evaluating progress, and the strength itself is the primary. Yeah. Where does say for instance you had a patient who had a developmental disability and was nonverbal and wasn't able to follow commands, and so of course the CK levels would be one aspect of measuring progress. Would then the muscle MRIs be probably the second or even the first as far as measuring progress?
I mean, I guess if I had somebody where I couldn't do a strength exam, then I would use this. I would use the CK, and that would be pretty good in this kind of myositis. Again, this doesn't apply to all the different kinds of myositis, but yes, if you have anti-SRP or HMGCR, we think the CK reflects disease activity. So if it were elevated, I would say there's some disease activity there. But this is that would be very tough to work to to figure out with a nonverbal patient and somebody who wasn't able to cooperate with strength testing to figure out what to do could be very challenging, you know, and it would I don't have a simple answer for that. I think some of it would be talking to the family. Are they not moving the way they were before? But it could be, and we might not know what the answer is. Sometimes what you have to do is just say, I don't know, I can't figure it out. Let's try getting more aggressive with the treatment and seeing if the patient gets better. You know, and usually I'll be like super aggressive for a short time and see whether it's working, and then if it's not, I'll back off. But I have it's not a simple problem, and I don't have a simple explanation. It could be if you can get, so some people with developmental disabilities would have trouble getting an MRI, but if they could get an MRI, that would be an additional piece of information that you could use. Yeah. Oh, no.
Okay, so now I'm thinking about, with all that we're hearing about in the most recent conferences and materials, that we should be looking at exercise a little differently than we used to. It used to be that we said if there was active muscle inflammation going on, you ought to be not exercising or doing it very gently or anything. If the CK is also measuring the degree of necrotizing, maybe, is there any guidance you can offer that says if your CK is high now showing necrotizing activity, here's some guidance on exercise, or just get out there and do it? Because I'm thinking when she's saying she's still weak, I'm thinking when I'm weak, it's because I haven't been exercising.
So nobody has specifically looked at exercise in patients with necrotizing myopathy. No one has done that. So we don't have any reason to think it's different than other forms of myositis, but we don't know 100% for sure. I think all of us currently would say you ought to be exercising, and we initiate physical therapy plans early in patients with necrotizing myopathies. Even people have very severe. You know, we have them even when people are non-ambulatory, in a hospital bed, can't walk. We've got them already working with physical therapy and rehab at those early stages, and I don't have any evidence that makes things worse. And from what we know from other forms of myositis, it shouldn't make it worse. But nobody's really specifically said, what about in SRP and HMGCR patients? One other thing I wanted to say about CK, just because I take it for granted everybody knows why it gets elevated, but that might not be the case. CK normally just lives inside your muscle cells, and very little leaks out. Some leaks out because we all have a little bit of damage to our muscle just from walking around, and the muscle gets repaired and everything's fine. But CK only goes up when the muscle cells break open, and they're breaking open because they're dying. And the CK leaks out, it goes into your blood, and that's where we measure it. And that's why in necrotizing, the CK always goes up when there's more necrosis, because there's more muscle damage. In dermatomyositis, sometimes people get weak without the CK ever going up because there's no necrosis of the muscle fibers, and the CK never leaks out. Again, with the caveat that if you don't have much muscle left, you don't see a big increase in the CK.
So just for clarification, if you are working out and basically you're breaking down your muscle tissue in order to be able to get it restored, is that leaking CPK then?
Yeah. So, excellent question. Some people get all worked up because their CK goes up after they exercise. I don't get worked up about that unless it also corresponds with people having weakness and getting weaker. Because even if otherwise healthy people exercise, their CKs go up. It varies by individual, but like if you look at rugby players, like serious rugby players, they've done this, like thinking of the team, average CK, about 800, you know? And I mentioned this before, if you're at the other talk, you know, people after they run a marathon, the average CK is about 1,200. If you're on a statin, it's 1,500, something like that. So, you know, the CK can go up and down, and with exercise. In some people, with genetic muscle diseases, exercise is not a good thing because they can have like a severe breakdown of their muscle, but that does not usually apply to myositis patients.
So again, how do you measure weakness? Because basically, when I go into the gym and I'm doing sets of reps, and then I get a high CPK, but at the same time, I know that I'm still being able to do as many, if not more, reps over a period of time, then it sounds to me like I'm not weakening under those circumstances.
Yeah, I agree with that.
Prior to the kickoff of this, I was in the gym 6 days a week doing insane things. My body fat was around 8%. And when at my highest, I was at 44,000. And they couldn't get me below 30,000 for almost 50 days. So during that period, I had obviously a lot of loss. I had to word this. What I'm wondering is the remaining healthy tissue, that's what I really need to focus on, right? Okay, just want to double check.
I wish that I had a drug to give people to convert fat back into muscle. And there are people who are very interested in that because it's a huge problem in muscular dystrophies as well. People with muscular dystrophy have a lot of fatty replacement, and so people are working on that. It's not tomorrow or next year, or probably even 5 years from now, but that's like a priority. People who work with muscular dystrophies would love to figure out how to switch that back.
Yes, I know my left shoulder, like when I started getting the side effects and the disease and everything like that, that was like, my left shoulder was like the first thing to go. And then when I know they did like some kind of like exam, whether it was like an x-ray or MRI or whatever, they saw that the muscle around my left shoulder had atrophied. And I know now, like in Canada, they have like infomercials, and it's on the webs, like on the internet and stuff like that, where they're doing like stem cell research and treatments now for like people that like athletes and stuff like that rip and tear the ACL and stuff like that. So I was saying, like, do you know any more research, or are you guys doing research here in America?
So there are people that are interested in exploring that. Right now, we don't know that stem cell replacement would work. Most of us who think a lot about these things don't think that that would be helpful based on what we know about the disease and what the stem cells might do. But I have to say we don't know 100% for sure. There are, potential side effects of doing that. It's really expensive. From our point of view, we'd like to see people who are, if they're going to do that, do it as part of a clinical trial so we can figure out whether it works or not. It's very difficult to know just treating like a single patient whether that's working. So I don't have a good answer for you, but right now we can't really recommend that kind of treatment.
I was thinking if you need fat to help with the muscles, can't you take the fat from somewhere else and inject it?
You don't want the fat. You don't want the fat in the muscles. Yeah. Yeah. If anyone can come up with a fat dissolving pill, they'll be very rich. Yeah.
I have a question about the control of inflammation. We've been able to keep the CK, actually bring it down to normal using the anti-inflammatory diet and supplementation. In a case like that, do you think we also need to consider, this is supposed to be IBM, but we got the typical biopsy that you talked about. Inflammation, no rim nodules, and necrosis.
Say what it was again?
The biopsy. The biopsy was inflammation, no rim nodules, and necrosis.
So what I would say is that when he comes back, we should just take a minute to examine him. Like it usually takes me about 5 seconds to figure out whether somebody has IBM. We'll see. Other questions?
I just heard about the new John Hopkins Myositis Center. Oh, is it? Where have I just heard of it? But Are they available? I should have just asked when the medical advisory board for second opinions.
Oh, yeah, we do that. We do tons of second opinions. Yeah, that's easy. Again, just my email's in there. Email me and I can send you the information on how to make an appointment.
I'm going to do that. I have a question. Well, it's a question because it's like I have the SRP, the anti-SRP mediated polymyositis. And when I was asking my neurologist, Dr. Robert Suffolk at Northwestern, about the IVIG, because I had talked to Bill Simmerall, who also has a PM, and he was saying that it pretty much changed his life. So I was asking my doctor about it and saying like, okay, well, since like Rituxan and the rituximab didn't work, can we try IVIG? And he was telling me like, oh, we'll only give you IVIG if you're on your deathbed. And I was like, I didn't quite understand why he wouldn't try that, but I was trying to see, well, is it maybe because of if they have high risk or something like that?
So most young people like yourself who don't have kidney problems, who've never had a heart attack or anything like that before, tolerate IVIG really well. Some people get a headache. That can be bad, but otherwise young people we consider to be pretty safe. IVIG is not necessarily our go-to thing for anti-SRP and in young patients, but we definitely have people with anti-SRP who have responded to IVIG. I use it a lot, right, in all kinds of types of myositis. Doesn't work for everybody, but I'm not your doctor. I don't know everything about you, but if you just ask me, what about if rituximab had failed and had anti-SRP, the IVIG would be a good choice. And the other thing is sometimes it's combination therapies that work. That it's not like, well, is azathioprine azathioprine didn't work and methotrexate didn't work, but sometimes azathioprine plus methotrexate work together. So the other thing is often young anti-SRP patients, I've got on 2 or 3 different medications all at the same time. So I might have them on Cellcept, IVIG, and rituximab. That's not everybody, but sometimes that's what it takes. And sometimes, as much as I hate to do it, I have to give them high-dose prednisone. So it just varies by individual patient, but it's often not a one-drug solution. It's usually, I would say more often than not, in somebody like you, it's multiple drugs. The other thing is young African-American women seem to be the toughest to treat with anti-SRP. So I'm just telling you that because it means you have to be, that's where you have to be super aggressive. So I like IVIG.
I'm guessing you're going to say it depends on the patient, but do you have a starting dose for IVIG that you like to start at?
So I almost always do, I almost always do 2 grams per kilogram per month divided over 5 days. That's what I start out with. Some people can tolerate getting all that in 3 days. Some people don't tolerate that for various reasons, and I have to go to a lower dose. That's my loading dose. And then I will do that for 3 months. I'll do that 5 days a month for 3 months before I've decided it's not working. Usually I see improvement after the first 1 or 2 months of it, but 1 month is definitely not enough. What I often see is people get 1 month of IVIG and it didn't really seem to do anything, so everybody's like, it didn't work. But that's not really a long enough trial. It's to prevent complications. Some infusion centers want to give it to people in 2 days, but the risk of not tolerating it is higher. And the side effects, the most common side effect is bad headache. People can actually get aseptic meningitis, which is like a chemical irritation of the covering of the brain, and people get bad, horrible headache. That's the most common thing, right? And you can reduce the chance of that by giving it over more days, giving it with hydration, giving it with steroids at the same time. There's a lot of things you can do to try to mitigate that if it's not tolerated well. In some patients, we've gone to go into lower doses. Instead of doing 2 grams per kilogram over 5 days, I'll do 1 gram per kilogram over 5 days. And for some people, that's enough to still get a benefit. So I always do that, and I do it monthly. And I do it for a few months before deciding whether it's working. And some people need it once. Not so much necrotizing myopathy patients. Most necrotizing myopathy patients are going to need it more, and that's individualized. If I get people under really good control, either I can space it out and try to go, oh, maybe I can get 6 weeks, maybe I can do 8 weeks, or I'll try to reduce the dose monthly.
Yeah, I've been on Rituxan for a few years, about once a year. It's let me get off prednisone. I'm still on Imuran. Do I just need to continuously do that? Is there a guideline for maybe trying to stop the Rituxan?
So, and remind me what you have again? SRP. So, I don't know the answer for how long people with anti-SRP need to stay taking the rituximab, and nobody knows the answer to that. Taking young people off it makes me very nervous, because I've had a couple patients who I had under pretty good control with various agents, not necessarily rituximab, but then when they started getting out of control, I couldn't get them back under control very easily again. So I'm nervous. I get nervous about it. So I don't know there is no right answer to that. If your CK is now normal and you're stable and we don't think you have any disease activity, that's the time when I might see if I can get away with it. I don't know if you get it every 6 months or every year, once a year. So I just don't know. If you're tolerating it and you're not having side effects and your insurance will keep paying for it, yeah, then it's like, man, I don't know if we should come off it, but there are, risks to being on it as well. So often it's individual patient choice, because some patients will be in your situation and they just really want to get off the rituximab. And they're like, well, let's just see what happens. And other people are like, no way am I going off the rituximab. So I don't have a good answer to that. Rituximab? So rituximab has a very different side effect profile than prednisone. Prednisone's the worst, right? Because almost everybody has bad side effects from prednisone. Yeah, sure, but rituximab, the main thing that we worry about is infection. And yeah.
Ask you that it's the JO1 and what else in JO?
You mean what antibodies to look for? I can send me an email and I'll send you a link to the website, to the company website that tells you what the tests are. Yeah, that'll be the easiest. Yeah.
So with the necrotizing myopathy, does it always spread, or can it just be localized in one place and then that's it?
You mean on the body, like
yeah.
deltoid?
Yeah, or like in the, where my son had it, it was in his thigh. He had a PET scan and they showed myositis in his thighs and his pelvic. Yes, exactly. And then one side, he had severe ossification on him to the point where he can't even bring his legs together anymore. He's in a frog position. I don't know if you've ever seen anything like that before. We don't know.
Yeah.
So, and the biopsy was necrotizing, and then they had fiber 2 atrophy, which I'm not sure exactly what that means.
Yeah, so fiber 2 atrophy you could get from steroids or from just disuse. If you're sitting around a lot, you can get type 2 fiber atrophy, or if you're on prednisone. Guaranteed type 2. Yeah. Yeah. Yeah, that's common to see type 2 fiber atrophy in all kinds of things. It's not very helpful with the diagnosis. So I would say knowing what the antibody is. Is his CK still elevated?
No, it's normal right now.
Yeah. Yeah, knowing if he had an antibody would be somewhat helpful to me to know what to say. Because if he had a no antibody, then not sure what he had. But it makes me more inclined to think it could have been just something that came and went. Viral? Possibly viral. So, but I wouldn't know. Yeah. It could. Yeah, usually that comes and goes. So it's common in kids, they get the flu. After the flu comes, they get weak. Their CKs are 50,000. They resolve on their own. So it's. He started with pneumonia, and then he had pneumonia a couple times, cellulitis once. Yeah.
Hospital stay.
Yeah. That's too complicated of a story for me to just figure out on the spot. I figured that's the case. This is that's a more complicated thing I can answer, and I might not even be able to figure it out. But the fact that his CK is normal now is good, and it might be very well worth repeating now that I heard a little bit more, repeating the MRI might be helpful, because then you could know whether the inflammation has all gone away. Yeah.
So if I have a normal CK, I think it's 40 actually right now, and I feel great. In terms of IVIG, I'm now lengthening out to every 5 weeks, 2 days back to back. Necrotizing myopathy. I know I do not have anti-SRP, and I'm trying to remember if I have the HMGCR, and no, I didn't take statins. So I'm not 100% sure. I go to Duke. She's told, or she'll send me the stuff, but I can't remember right offhand. And I know I don't have anti-Jo. But do people eventually get off of IVIG? And also, although at one point in terms of prednisone, I went down to 4, and then all of a sudden the disease started kicking in, and it wasn't bumped up. That was last year in the spring. And for some reason, it happens every 2 years ago, 2014 in the spring. It seems to hit exactly the same time, almost seasonal.
So what I would say is if your CK is normal, that's a really good thing. And in terms of whether you can come off the medication or not, it's really trial and error. If you've tried before, like if you were like this before and you tried coming off and the disease flared, it makes it more likely that the same thing would happen again. It doesn't make it impossible, but it would make me more wary. But I definitely have had patients where we've gone through cycles of this, and they continue to need to be treated. Sometimes we can, like you go for longer and longer periods of time between the IVIG or whatever the drug is. But sometimes people require it. I have one patient who has anti-HMGCR. He does pretty well on just methotrexate. But then every once in a while, his CK starts to rise, and it'll go up to a few thousand. I have to give him IVIG, and then it comes back down again, and he's fine for a number of months. But every once in a while, I have to give him more IVIG. My question is, does the methotrexate helping him or not? Actually, I don't know for sure that it is. It may be all the IVIG that's working. But I guess the point is you have to just do trial and error sometimes to figure out whether it's working. So if you tried it, if all you're getting is IVIG, how high is the prednisone?
This year I started feeling it again.
Yeah.
And I'd only gone down to 14.
Yeah.
Haven't cranked up to 30, so now I'm down to 23.
So people who are on prednisone plus some other drug, the answer is always to try to get rid of the prednisone first. So before starting to think about whether I can get off of the IVIG, the first question, because the reason that you're taking those other drugs is so that you can lower the prednisone. So, so that should be goal number one. And then if you've tolerated being off the prednisone for 6 months or a year or something like that, maybe only 6 months, then it's the time to think about, should I start getting rid of one of the other medications? Did you? Yeah.
I'm kind of confused what you can see with the MRI. Can you see active necrosis as opposed to inflammation?
Yeah, great question. So on the MRI, what you can see is there muscle there or is it fat? The other thing you can see is there, what you're really seeing is edema in the muscle. And you'll see that whether it's necrosis or inflammation. I can't look at a muscle MRI and tell you that's necrosis or that's inflammation. It doesn't distinguish between the two. Still won't help me. The only thing that'll tell me whether there's necrosis is whether if I take a piece of the muscle and look at it under the microscope. If it was necrotizing before, there was more, like it's going to probably continue to be that way. Yeah.
Oh, yes. Okay. I've been tapered down off the prednisone before, but the only thing that they were doing was the plasmapheresis or the plaques. And once they tapered me down and I was off the prednisone, like within like a week or two, I felt the symptoms come back, and then when I went back, they put my steroids back up extremely high. I didn't go to 1,000 this time, but I went to I think maybe 60 or 80. And now we've tapered it down to 5, but they added the methotrexate. Last year in August, I was on the pill. And then slowly over time, they increased the methotrexate to 30 milligrams. Then they told me that my body wasn't absorbing the methotrexate, so then I got on the Rezuvo, the shot. And now they just did my lab work 2 weeks ago and checked my CPK levels, and I went from being 526, now I'm in the 1500s. So it's I don't know what else to do or what else to add on, because it seems like every time we try to taper down off the prednisone to get me off, it flares right back up. But I'm still able to move on.
How long ago did you take the rituximab? And what other medications were you taking while you were on the rituximab? Yeah. 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 So again, you're pretty complicated, and it would require more digging to figure out exactly what the appropriate thing to do is. I mean, again, you're going to be one of the tougher patients to treat, but it may be that rituximab, along with a couple other medications, might be effective. I don't know for sure. The other thing I would say is in anti-SRP patients who have failed all the other kind of things that we've talked about, what we will next go to is what we call immunoablative cyclophosphamide treatments. So it's a drug called Cytoxan or cyclophosphamide. It's really like a chemotherapeutic regimen, like what we might treat somebody with who has cancer, to try to really reset their immune system. The risks of doing that are not small. It's a serious deal to do it, but we've done it in some of our anti-SRP patients who have failed really aggressive treatment, and some of them have done extremely well. In fact, we can talk to Lisa Christopher Stein. We now have 8 people that we've treated with immunoablative cyclophosphamide therapy. I believe all the anti-SRP patients have done well. Our anti-HMGCR patients who were young didn't seem to do as well, but it's only 2 patients. But that would be if we sat down and looked at everything and we're like, man, we did the rituximab right, we tried it with another drug, we've done all that we can do, and you're still getting weaker, then immunoablative cyclophosphamide would be probably our next step. We don't even do that ourselves. We have colleagues in oncology who we refer to, and we say, look, we have a patient with really severe autoimmune disease, and we do it for other things like myasthenia gravis and other severe diseases. They know how to do it, but that is a potentially realistic thing for you. But again, it requires really going through and making sure that we tried all the other things in the best possible way. Oh yeah. Okay, everyone's going to examine the guy. Okay. Do you mind if we examine you real quickly? Are you up for that? You don't have to. It's a voluntary, totally voluntary. Okay, I'm going to have you sit right over here. How about that? All right, can you hold? No, he doesn't have to get naked. All right. You take your glasses off, you close your eyes super tight. Don't let me open them. That's pretty good. Arms up like this, super strong like that. Don't let me down. Be super strong there. Big muscles like that. Pull me here and push me away. Whoa. Push me away here. Good. Make your wrist super strong like that. Don't let me down. And then wrist down like that. That's a little bit weaker. The wrist flexors are a little weaker. That's a little bit weaker. Fingers straight out. Don't let me push down. So super strong. Super strong. Turn your hands over like that. Squeeze my fingers. Your fingers are not normal. Those are weak. And squeeze it right. That's weak right there. So that's IBM. That's almost certain. Very. IBM is easy for me, actually. The question, the people talked about NT5C1A and muscle biopsy and stuff. The question I really have is usually when we see somebody like this with the right story, and I didn't examine your legs, I'd want to do that too, but sometimes we don't need a muscle biopsy or NT5C1A. We can just look, and it's like, you look like the classic inclusion body myositis patient, and I can see your quadriceps. Can you walk like this? That's actually pretty good. Yeah, okay. But I'd bet money that's IBM, no matter what anything else says. Yeah.
So here's the question on inflammation. We've been able to bring the CK and all the inflammatory markers down to normal with the anti-inflammatory diet and supplements. Do we need medication in addition?
I wouldn't recommend medication for you even if that hadn't worked for IBM. IBM is like a totally different animal than the necrotizing myopathy. I have seen a couple of IBM patients who have predominantly necrotizing muscle biopsies. Very few, but a couple. But also inflammatory cells. So if you have again, it highlights that the biopsy is marginally helpful for me, to be honest with you. Just examining you is worth more than like repeating biopsies or even looking at your biopsy, because I don't really care what your biopsy shows now. Like, I'm pretty convinced you have IBM. Yeah.
So they were talking about that, I guess, that failed clinical trial for that IBM drug. They did say it increased muscle. To me, that would be a good thing.
Right, you're right. So that drug that they were using for IBM, here's the story behind that drug, as I understand it. That drug is designed to build muscle mass. And it should build muscle mass in just about anything. And that the companies are trying the drug in multiple different diseases. One thing that they chose to try it in was IBM, because it's like an orphan disease, and it was actually pretty easy for them to like fast forward this whole thing in that patient population, because there's no other treatment, people are really weak, there's desperate need for a therapy. So if they could have proved that it works in IBM patients, it's a home run for them, because then they can sell that drug off-label, for other patients. So I think that the IBM trial was their way of trying to get it out into the market early. But they're still doing trials with that drug and other drugs that do the same thing in people who have like broken a leg. If you break your leg, it's in a cast, you're going to get atrophy of the muscle. It's a significant problem. People with cancer get muscle breakdown. Older people get muscle breakdown. All that's just called sarcopenia. They're now doing trials in patients who've had like hip surgery, who are casted, some of them getting that drug, some of them not. And if they can prove that it works to build muscle mass for those patients, they'll get an FDA indication for that. And then people can prescribe it potentially off-label for other things. Now, insurance may not pay for it, so that's a whole other issue, right? But I wouldn't be surprised. That drug, I think, is going to work. It seemed to work in IBM, actually, as Dr. Greenberg was talking about. Even though patients couldn't walk farther, their muscle mass had actually gotten bigger. So probably, I think, and I could be wrong, but I would bet money on that working for those other indications. Maybe it won't, but it seems like it's a pretty good bet that it might. And they're investing a lot of money into that. So if it got approved for that, it might be good. Maybe it's good. Maybe we ought to be treating myositis patients with anti-SRP with that drug like on day 1 to prevent fatty replacement or something. I don't know. So it's not available. It's not on the market. It's a drug that's being, don't get too excited. Like, who knows? I'm just saying that this drug that they had a trial for IBM, even though it didn't work in IBM, it didn't work in the sense that it didn't meet what they decided ahead of time was their endpoint. There was still a lot of other things that they looked at that looked like it was, made it look like it was doing something. Yeah.
This will be a little easier question, hopefully. Regarding a PET scan, does a PET scan provide you any more additional information than a muscle MRI does regarding myositis?
So that's a good question. I have never ordered a PET scan to evaluate myositis disease activity. I actually don't know a lot about it. I've never had to do it. I order PET scans to look for malignancy when I think there might be a malignancy, and they will report on the report that they can see evidence of muscle edema and myositis. So it's a good question that maybe it should be easier, but not for me, maybe somebody else knows. I don't know how it compares to the other, like an MRI, for example, in terms of sensitivity and what it can tell you. I don't think people have looked at it that much in myositis, but they definitely can see changes on PET scan in myositis. Yeah, yeah. Pretty unusual route to get to the diagnosis. Yeah. Somebody? Have I worn you? I've worn you down? No, it's not a problem. Yeah. Oh man, it's 5:25. Okay. All right. So I guess that's it. If you have any questions, you need like specific information, you want to schedule appointments or find out about the antibody testing, you've got my emails in the booklet. Don't be shy. Just send me an email. Not a problem. Sure.